Hello everyone. So welcome to this live session. Now in this live session I'll be doing this from the point of view of the OSCE so that we can have an overview as to what kind of images can be asked in the interview. This is mainly regarding the All India Institute of Medical Sciences, the interviews pertaining to that. And so I got a lot of requests and I thought that I should take this up. Now, you have to understand one thing, that whenever you are appearing for, interviews for MCH entrance, now, what are they actually looking for? They're not looking for your in-depth knowledge, or they don't want that, you should be knowing everything about plastic surgery. Here the question is different. Here they are testing your aptitude. Here they are testing your presence of mind, or how you manage a situation, whether you are able to come to the common conclusions or not. So these are the most important things that a clinician or the examiner is assessing when they are interviewing you. What is important is that when asked, rather than going into the theory, see, theory exam you've already qualified. Now when it comes to doing the clinical assessments, then you'll have to kind of really think on the go, and you have to have your reflexes intact when the examiner is asking you a question. They're not expecting you to know everything about a topic, let me tell you that. What they are expecting is that how you approach a case and whether your approach is right or not, because most of it will be already what you've read. So don't be scared as to, I don't know what they'll ask. So try, and again, management, treatment, all this is mostly a part of theory. Mainly what they are going to assess here is your approach and your aptitude. These are the two things which are important. And in this video, I'll just be running through a few clinical images, and so that it can just get your brains working so as to how to think when you are asked a question. Now let's come to the first slide. Now what you have here is, you see some skin, and what you see here is some kind of a whitish patch. Now when you look at this image, it already says identify the scar in the image. So what you have to think is that what kind of a scar it is. So obviously it's an atrophic scar. Now what is the etiology, or suggest the possible treatment and how to avoid it. Now let's say that these are just guideline questions that I have written. So let's forget about the questions that are written in the slide right now. So how can this image lead you to different questions? So let's say that you identify this as a scar. Okay, the examiner asks you what kind of a scar it is. So when you are describing the scar, if you describe it as an atrophic hypopigmented scar, it is the best appreciated answer. So it's an atrophic hypopigmented scar. Possible etiology, get your brains running. You know that if we are using triamcinolone, intralesional triamcinolone, it leads to atrophic scarring, and that is the most common cause in these cases of atrophic scarring. So hypopigmented patch, atrophy, always think of intralesional triamcinolone. Probably this area has been overtreated with steroid, and how will we avoid it? We will calculate the maximum dosage, and according to that, according to the intervals, and every time you assess, and that is how you avoid this complication. It can also lead to fat atrophy, under the dermis, so that also leads to the atrophic scar. So obviously the management comes later, and most likely, they will not give a lot of points on telling the management. So how you approach this, whether you are able to identify the common things or not, is the question here. Let's come to this image. So this is the the leg, image of a leg with some lesion here. So what this picture is trying to tell you, if the examiner asks you that what is the picture trying to tell you, let's just say this. So it's on the leg, possible growth, where we are measuring the margins. So we are probably thinking of some kind of a malignancy. So it's probably a squamous cell carcinoma. What does the picture tell you is that the clinician is trying to take a margin of resection. Now that will bring you down to what are the possible margins of resection, how do you ensure. Now most importantly here in these cases is that they can also ask you, common questions as to what next. Once you've resected, then what will you do with the specimen? So if you're asked to describe the entire procedure, then let's say if you're doing it under spinal anesthesia, for example, then what do you do? Under spinal anesthesia, you paint, drape, then what you will do is you will mark the margins, you will take the margin, you will remove the lesion with the concerned margin. Then what will you do? It's important to label the specimen, because it's a circular specimen that is going to come out. You will not be able to tell which is superior, which is lateral, which is medial, which is inferior once you are not mindful. So after removal of the specimen, let's say that what next is the question. Then what do? You will not say that I'll cover the wound. The first thing is that you have to put the biopsy specimen in the proper orientation. You have to label it, whatever it is. Usually what is done is short superior and long lateral. That is how we do it. So silk sutures, small suture on the superior aspect, longer on the lateral aspect, so that you can actually mention it to the pathologist and they can tell you whether the margins are clear or not. And then comes the option of coverage. So in this case, the most common thing that you can do is, instead, you will not need a flap for this. A simple split thickness skin graft will do the job. So again, when you are approaching a problem, then how you approach it. That means whether your plan is okay or not, whether how much margin you will take is the less priority, but that you have to take a margin. Why do you take a margin? For clearance. And then after that, what do you do? Once you have resected the specimen, then what are you doing? Then you have to label it for the biopsy, and then comes the coverage of the wound. Now when you cover, then what is important? Let's say that you've covered it with the split thickness graft. What is more important here is that once you've resected, you are sure that you've resected a clean margin. The base is also clear. Then if you're taking a split thickness graft, then how will you fix it is the next question. If you fix it with suture, do you immobilize or you don't immobilize? Whether you are putting a splint or not, yes, you will put a splint, one joint below, one joint above, you will immobilize. And then when you are removing the dressing, on what day will you remove? On the 5th or the 6th day generally we will remove the dressing. And after that, continued immobilization for a few more days, maybe a week or so. And after that, assessment, and then you can you can remove the splintage once you know that the graft is fixed. It can lead you to theory question. If the examiner is really interested in testing your theory knowledge, then they may ask as to, what are the stages of graft healing, when revascularization takes place, and all that we've already discussed in the lectures. But it is more important that how you are approaching a case, and spot diagnosis usually should not be missed. So in this case, this is the leg, it's a growth, it is an SCC, margin has to be taken, and in the non-essential area, we can take a larger margin also. And for example, in the leg, if this was the face, perhaps the margin would be a little smaller. Now, again, this image, what do you see in this image? So what you see is that there are a few things that we can see. Number one is that a flap has been used to reconstruct the left breast. What else do you see? What kind of a flap it is? You're able to see in the figure itself. You see that there is a horizontal scar here with an umbilical scar also. So possibly it is a free flap. Most common option is DIEP. It could also be tram, but most common option is DIEP. Now it can lead you to questions regarding what are the other options. Let's say if you say DIEP, then the examiner may ask that what are the other options for reconstruction in the breast. Then here what you also have to see is that it is a partial skin sparing mastectomy. So here some skin has been spared. You can see the margin of the flap is here. So it is a partial skin sparing mastectomy. Now what is the advantage of the DIEP? See the bulk that it has provided to match with the opposite breast. that is the main advantage of this DIP flap, that it provides bulk, it's a stable flap. And then what other questions can arise from it? You can be asked as to, let's say, why do you say that it's not a pedicled flap? Then a pedicled flap will have some elevation over here on the underside that you can't see, so possibly it's a free flap and not a pedicled flap. Now again, various other options as to whether primary reconstruction is better or secondary reconstruction is better, what in the primary reconstruction you can use, what are the other options. For example, they can ask you questions on LD muscle also, then the blood supply of the LD muscle, and when you are then it can also lead to questions about implant with LD muscle usage that I've already discussed in the breast chapter. You can go back and revisit, but basically what the examiner will want to understand from you in this is whether you are able to identify what is the reconstruction that has been performed here. Then also the zones. You remember the 1, 2, 3, 4, that is important. The zone 1, 2, 3 and 4. What is the least usable option? Least usable portion is the fourth portion. So basic questions. It can lead you to the classification of the muscle flaps also. That also again theory, but you must know. And these are very common questions that you cannot miss. Now coming to this, here it's a congenital hairy nevus. Now in this, let's say that if you are asked to observe closely what has been done. Now if you look closely, you can see a scar here. Why is this scar present? What are the possible reason for this scar to be present? It can be that a biopsy has been done from this. A biopsy to prove what is the current pathology, and then this the resection is done purely from the point of view of cosmesis, and if the resection is done, then here the clearance cannot be attained because you see there's so many satellite lesions. So if you are wanting to remove only the bigger portions from the point of view of cosmesis, then what will be the possible option for coverage? We can't use an expander. Expander are anyways not good options for the limbs. What is the possible option of coverage after you remove this lesion? Then the possible option of coverage will be split thickness graft. Again, it can lead you to questions for, let's say, fixation, or what is the thickness we are expecting in this. In this we are doing usually we'll do an intermediate thickness graft, not a very thin graft, because likely that this lesion will be debrided or will be resected a little deep. So just a very thin graft will not do, because the thin graft will also contract. Then it can lead you to questions like which contracts more, whether it is FTG or SSG. Is FTG an option here? And if SSG, then what are the possible donor sites that you would like to use in these cases? So again, these are skin graft you can get from anywhere. Any question can lead to a skin graft. Viva. So all that you have to keep thinking as to what can be the best possible answer when a question is asked. Now let's say that you were presented with this. Burns are very common to be asked, so you have to again be very thorough with the chapter on burns. What is the depth of the burn, the Jackson's zones, so that is also very important as to the 3 zones, and again how the resuscitation will help those zones. All that is also important. Now you see here what is this wound? It looks like a burn wound or a scald wound or scald. Then what will you do? How will you approach this case? So let's say that so you see it's the knee that is involved, the region of the knee that is involved. So when you are seeing this case, if the case is presented to you at this time, then what do you think? It's a slightly older burn wound. It doesn't look like a very fresh burn wound. So what will you do at the first instance? If you say that I will dress the wound with this and that, and I will do a dressing, I will counsel the patient for SSG or for grafting, or I will put a split thickness skin graft or whatever. All these will have no meaning until unless the examiner will hear from you that first what you will do is a pus culture sensitivity or a wound swab. It's very important. So this is like, common things have to come first. If you miss saying that you will debride, or you will send the wound swab, and then you will counsel for debridement and cover, or optimize the patient for a graft first and then only graft. So these are important things before you utter that you are going to graft this patient in the first go. So these points are important as to how you approach the case. Of course, you see a large wound, you see a red wound, graft is the option. But what is the examiner wanting to hear? The examiner is wanting to hear your plan before the graft. So that has to come before you utter that you are going to cover this with a split thickness skin graft. Now, obviously, when you're doing this, let's say if it is dressed, then what will you do? You will wet the dressing properly. Then you will remove the dressing. After that, you will send a wound swab culture. You will take a wound swab culture. Then you will assess as to what is the extent of the wound. After that, if the joint is being involved, then you will provide splinting. From day one, you will provide. Even if you've not done a graft, then also you will start providing splinting. Physiotherapy is important. Wound optimization is important before we plan for a split thickness skin graft. So then what we'll do is once the pus culture reports come, we can decide the antibiotic accordingly. You can even call for regular dressing, optimize the wound, granulating bed is available. Then you will do the split thickness skin grafting. When you do the split thickness skin grafting, then what are the other things that you will do? You will definitely splint, and after the graft has taken, then you will advise physiotherapy, prolonged physiotherapy, pressure garment, massages, all these will come later. So again, approach to the case is more important. Now, let's say that you're presented with this image. It's a spot diagnosis that it's a meshed graft. Now, in what cases we use mesh graft? When usually when the graft requirement is too much, or when we are dealing with comorbid patients. So here, let's say that what all can you see in the picture? You can see in the picture that the bed is a granulating bed. You can see it's a red. A granulating bed is there. The graft has been fixed with staples all around. And then the next question comes, how will you immobilize the graft? If at all, if you are given this patient, then is this a complete, or you can just cover and cover with dressing and you can let it be? No, you can't, because you've not immobilized the graft. The graft will not take until unless you immobilize it. So what are the options for immobilization? So what you can do is you can put a tie over dressing, but if the examiner tells you that it's the lateral trochanter of the right thigh, so the right lower limb, the lateral trochanter, then how will you immobilize it? Immobilization is difficult in these cases because you cannot immobilize the hip. So how will you, what will you do? In these cases, the best option for immobilization is, so you can do a negative pressure wound therapy that immobilizes the graft very well. It will increase the chances of graft uptake also. So here again the approach to the case is important as to if you are presented with this patient, you've done a meshed graft, then what is the next step? The next step is definitely immobilization of the graft, and then options for immobilization you will need to know. And here the best option is this, because it's such a granulating bed, it will help in taking away the secretions and then adhering the graft to the wound bed, and the chances of take of the graft will increase. Now again, this is an image you can see, commonly asked syndactyly. Syndactyly, most common question is types of syndactyly, simple, complex, all that, complete, incomplete, it. How will you manage it? How will you manage it is whether, let's say that, if instead of the toe, you give in the fingers, whether you will do both sides together or you would like to do one by one. We've already discussed it that both sides together is not done, and we will avoid operating on both the sides of the finger because it will put the vascularity at risk of the finger that is in the middle. And how we manage it? We manage it with the with a flap based design. Now why this quadrangular flap, for what it will be used, and why this zigzag flap? So you may be asked that, you know, what is your plan of action and how will you release it? So this, they can ask that, you know, what is this rectangular flap used for? So you know that the answer would be the web space creation. It is used for the web space creation. The zigzag method is used so that the contracture does not happen. And then, will you need an additional cover after this or not? Yes, you will need a SSG or an FTG. In children, mostly FTG is used, and the best option is definitely a full thickness graft. And then, you know, it can lead to just, you know, types of syndactyly and whether nail is involved or not, and you know, maybe a couple of syndromes related to syndactyly. So it can lead you to that, but mostly what they ask in syndactyly is the types of syndactyly and how will you release it, what is this quadrangular flap used for. So all these options you have to know, and whether you will release the adjacent digits together or not. Now coming to this, if I tell you that this is the right shoulder, or this is the right shoulder, that's the axilla you are seeing there, that's the chest wall. What you can see here is a partially covered defect, you know. So this looks like a muscle cover here. So let's say if you are asked to identify this image, then what you can see, how we describe it is, it's a partially covered defect of the right chest wall. Now possible etiology that could have led to this defect is, you know, it could be a locally advanced breast cancer can lead to such type of defects. And here what is the muscle that you can see at the base? What is the muscle that you can see at the base if you are asked to identify? So the pectoralis major muscle. Will your answer be pectoralis major muscle? Because that's the muscle that is present here. So if you say this, it is likely a wrong answer. Why? Because if you see, the direction of fibers are like this. How does the pectoralis major muscle travel? It travels like this. So then, get your brains thinking as to what this could be. You see that a muscle, that a flap has already been placed. You can see a fold over here. So likely this muscle flap has come from the back, and the skin cover has not been taken enough to cover the entire thing. But here this muscle is a part of the same flap. This muscle is a part of the same flap. Now, if you think of the latissimus dorsi muscle, if you remember, if you see, this is the back. If we are talking of the lat dorsi muscle over here, that's the lat dorsi muscle. Let's say that if we have planned for a skin pedal like this, what do? We have taken a cutaneous portion, and this is the muscle portion. The muscle has been taken larger. So this entire muscle that you see here, this entire muscle has been taken. So this is the skin with the muscle part that you can see here, and the other part is only the muscle, which is this portion that you can see here. So obviously the muscle, the latissimus dorsi myocutaneous flap, it's covering the entire defect, and here what you can do is you can put a skin graft because the muscle is there beneath it, so a skin graft can be put on this. So here the chest wall defect has been covered with an LD muscle myocutaneous flap, and an SSG is needed on top of it to cover this as well. Now coming to another scar picture. Now if you have to comment on the nature of this scar, if you compare this with the first scar that we saw in the first picture, it was a hypopigmented scar. So is this scar hypopigmented. But what is the difference that you find between the first picture and this picture? that scar was atrophic. This scar is not atrophic. Here you can see that the dermis is proper. I mean, there's no atrophy in this scar. Rather slight hypertrophy you can see, but it's not an atrophic scar. So what is it? It's a hypopigmented scar, likely due to a burn. And what can lead to this hypopigmentation? The hypopigmentation is because of the depth of the burn, because the burn has gone to the dermoepidermal junction, and that is why the melanocytes have been destroyed and there is no pigmentation present in a few portions of the scar. What are the likely options for treatment in this case? So what we do, we simply remove the upper layer. We either do dermabrasion or just slice it with the Humvee's knife, and then what we do is we place a thin graft, because here it's not the structural problem, but it is the problem of color. So we just need melanin here. We just need melanocytes here. That means the options can be two. Either it can be melanocyte transfer, where we are not really taking a graft, but we are processing the thin graft or epidermal grafts for melanocytes only, and we can do dermabrasion or removal of the upper layer of the epidermis, and then what we can do is we can just spray the melanocytes here and dress, and eventually the melanocytes will take up and slowly the pigmentation will start appearing. Or we can do a dermabrasion in skin grafting or excision in skin grafting simply. So the difference, this is not an atrophic scar, and you cannot say that this has occurred due to the effect of intralesional triamcinolone, possibly due to hypertrophic scarring, because that will be a wrong option. Because if the hypopigmentation is there, then likely there would also be slight atrophy, which is not present in this case. So here it's different from the first image. Now in this, again, you will not be asked too many details, but what can you see in this diagram? What you can see is that it's possibly a burn wound of the hand with certain deformities. What are the deformities that you can see? You can see this deformity is a swan neck deformity. This is again a flexion contracture. That also you can see, this is a flexion contracture, and you can also see a palmar flexion contracture which has been released. What are these dark patches? There has been a graft that has been placed already after the release. Now you can be, apart from the treatment is again, as I told you, it's the last. What you can be asked really in this case is that, let's say a burn wound of the hand has come to you, how will you manage it? So you should know about how you will dress it, what are the functional positions, the glass holding position, splinting is important, physiotherapy is important. So all these will be beforehand. So these, and if at all the depth of the burn is more, then what we do is we graft initially only. We don't wait for the contracture to develop and then graft. So obviously the management will start right from day one, where you are dressing the wound, where you are splinting it in a proper manner, where you are doing physiotherapy. So all these will come before you can say that we will graft the wound, or we will, manage it with contracture release or whatever. So first you have to say that in the initial phases only, proper burn depth assessment, so that proper timely treatment from the skin graft can be done. Splinting is important, physiotherapy is important, compression garment is important, massage is important. All these are more relevant to the management than later on what we are doing here, the contracture release and the deformity corrections and all. Again, coming to this diagram here, it's again a spot question, where you can see that there has been a left mastectomy that has been done. Now let's say that if you are just given this without the text that has been written on the right side, you forget about the text. Now let's say if you are presented with this, can you really mistake it with the Poland syndrome? Is it possible for you to mistake it for a Poland syndrome, that the left breast has not developed and it could be a Poland syndrome? But I mean, it is possible that you mistake it. But what you can really see here is the contraction of the skin that is present around the nipple area. You can see some scar that is present around this place, and here, so possibly it's a case of a mastectomy, which has been a nipple sparing mastectomy, nipple and skin sparing mastectomy has been done. So this has been done, and again, in Poland syndrome also, some kind of deformity of this pectoralis major muscle is also expected, which is not present. So it's not really easy to mistake this as Poland syndrome. Now, let's say that the examiner mentions that, okay, fine, this is a resected case of CA breast, and what are the possible options that you have for reconstruction here? Now, what you see is that we have to create, what is the most important thing that we have to create here? We have to create mainly the bulk. So what are the possible options that are present? So let's say that if the examiner says that the patient does not want any other scar besides this, then what are the possible options? So you have to know that we can do an expander and we can do the implant later on. So these are this is the basic that is expected from you, that expander followed by implant is possible. And because let's say if radiotherapy has to be done, then later on we have to know that, how we can plan. So expander can be placed beforehand only, the radiotherapy and all is done. After that we can expand. Another important thing is that if fat grafting can be done, then it will help with making the skin healthy again, because the radiation will cause a lot of contraction around the skin, and that is exactly that we've done in this case. Is that in the mastectomy, at the time of mastectomy, we've grafted a little fat on the muscle, slightly in the skin as well. In the second session, we grafted fat again. So slowly we build the cover of slowly we build a little bit of tissue around the breast, and then we can put the implant, even without resorting to an expander option. So, but just putting it simple, expander implant is the common answer that is expected if the examiner says that the patient does not want any scar. So again, approach to the case is important. You have to identify what is present first and then how you can solve. Again, the question can take you to options of breast implant or breast reconstruction. What is primary reconstruction? What is secondary reconstruction? So, just the common questions around that. Again, coming to this, what can you see here? You can see a certain shape which is elevated. So, you can be asked as to what is the etiology of this. So, what you can see here is just a hypertrophic scar, or rather you can say query keloid is possible, but since it is spilling out of the margins probably. But here, besides the management, what else is important to identify? What is the possible etiology? If you can just think, what is the possible etiology? There would have been a tattoo here, which has possibly been removed. By which modality? How can you remove the tattoo and still retain the shape? It has been probably laser that has been used to remove it. What is the most common laser that is used to remove black pigment? So, it is Nd:YAG 1064. Then you come to this, that okay, what is the possible complication that has occurred here? It may be that during the laser sessions there was a burn, there's an injury, it has led to the keloid formation. Then how will you manage? Of course, the option is intralesional triamcinolone. So, what happens is that when you are preparing for an entrance, always your brain has been wired for the ultimate solution. So, you have to rewire slightly for the interviews. You have to start thinking more simply, more commonly. So that is important, because once the image is presented to you, suddenly you'll always have flashes as to what is to be done. So before that, there comes the planning, the execution, etiology, a lot of things. So you have to start thinking about those things. Well, then those are the things that the examiner is really expecting from you as to how you approach the case. Again, coming to another burn wound image. So you see that it's an extensive burn that we are seeing here, but what are the possible questions here? If I were the examiner, I would ask that how do you avoid this complication? Even for a very experienced plastic surgeon, it's a very difficult problem to treat. So how do you avoid this complication is a more important problem at hand. So if, let's say, you are given to manage a burn like this, then how will you approach this case? How do you avoid? So you have to think that had this patient presented as a fresh case, what would you do? Obviously, it would have been an extensive burn. The grafting has, the grafting should have been done in the initial phases. The contracture should not have been allowed to form. So the breast release is needed over here. So if we initially only recognize that the burn wound depth is so much that it needs to be grafted, so obviously resuscitation and all, post that, how do you avoid this complication is once you've saved the patient already, then definitely early tangential excision or early excision and grafting is needed in these cases, and then post-operative conservative measures like massage, physiotherapy, all this is needed, and so that this complication can be avoided. It's beyond the scope of your knowledge to answer as to how to manage. Nobody will ask you and nobody will expect that you know the management of this case, but they will definitely ask you how you avoid reaching to this stage. So that is important as to early excision and grafting, and then post-operative protocols. I don't know if this picture is very clear, but if you can diagnose the pathology and its management. So what you can, if you look closely, I'll give you just a minute to see what you can see in this photo, and just make things a little easier for you. Divide this into two halves. Now compare the two halves. What can you see? There is definitely more fullness on this side, atrophy on this side. Is that visible? You see the cheeks are more full. This part, see, this is sunken. Even the forehead also, now you can realize. So I'll just take away all that I have written. See again. Compare the nasal ala as well. See, this nasal ala is bigger, this is smaller. So obviously we are dealing with something called Romberg's disease. So there is atrophy on half of the face. Here what happens is that, again, you will be asked, let's say that, what is the most common, how do you treat this most commonly? So it is by fat grafting. You may be asked as to how you will deal with the nasal ala. Again, not important for you to really know, but this can be dealt with a composite graft with the cartilage and the skin, and that the donor area will be what? Yeah, this can be asked as to for the composite graft, what can be the donor area? It will be the ear. Okay, this again important. Identify the pathology, what possible pathology on the nose, fair skin, could be PCC, could be SCC, anything you say can be correct, but more importantly you will be asked is how do you think will you manage this case? Again the same thing, margins, orientation, marking, biopsy, possible cover, what will you do? So the most important thing to know here is forehead flap reconstruction. Forehead flap you will need because this will have a large margin of excision, and the defect that you will see will really become this big, and you can do a forehead flap. But also other options like the mitre flap and all the local options also you should know. You should know about the VY advancement that can happen. The VY advancement also is a possible option, but obviously the first option will be forehead flap. There's no mistaking about that. All the other local flaps can be you can be also led to be asking about the bilobe flap, bilobe flap design. What is transposition flap? What is rotation flap? One thing leads to the other in this. So this can lead you to discussion about the local flaps. It can lead you to discussion about the forehead flap. So all this you have to know. And the next image is what I was just talking about. So you may be asked, what is the reconstruction that has been performed? You know that it is a VY advancement that has been performed. What is the possible pathology that has been dealt in here? Possibly a sacral pressure ulcer that we've dealt with here. And then again it can lead you to the local flaps, transposition flap, locoregional, the faciocutaneous flaps. All these are options. What are the other local options available? Rhomboid flap discussion can be possible after this. The gradation of the pressure ulcers is possible in this question. So common things again, and basic things you should not forget. If you're taking up a case, you will first obviously say that you will see what is the comorbidity of the patient, how you will position the patient. All these are important if you're dealing with pressure ulcers. Mobilization post-op is also important, because if you're treating one ulcer, if you're immobilizing in one position, it will lead to other ulcers. So these are practical problems that we face when we treat patients like these. Now here, identify the marked image and suggest the possible management. Here basically what the image is trying to show is crow's feet, and what is the possible management? Common management is botulinum toxin. We've already discussed about it. And again, not very important, but just that what is the special name? These are crow's feet. And how do you treat? It is botulinum toxin. Botulinum toxin, you will need to know what is the mechanism of action and how often it needs to be repeated. That's all. Here, I don't know if the image is very clear to you, but you can see some kind of so these are two images actually. If you see here, two images. So in the first one, this is the sideburn, and you can see something which is slightly grayish bluish. So possibly we are dealing with a cyst here, most likely a sebaceous cyst, and then it can lead you to discussion about the sebaceous cyst. More importantly, it can lead you to discussion about Langer's lines. What will be your plane of incision? How do you ensure that you've taken out the cyst completely? And again, of course, when you are describing your plan of management, a biopsy is a must to say. You should not miss the biopsy. So, okay, so that is again simple things. These are not very important. Again, this is another burn wound that we've come to, but this is important here. This can lead to describing the degree of burn wound. In the management, they will want to hear from you whether you are advising limb elevation or not, whether you are advising closed dressings or not. And then because it's a deep wound, most likely it is not going to heal on its own. So tangential excision you should know excision and grafting when you do tangential excision. And then again leading to same questions about split thickness graft, about immobilization, about wound bed preparation, about pus culture sensitivity. All these are questions that can be asked. Now here, this is a case of gynecomastia, common problem, very common problem in fact, and you can be led to be asked about the grades. How will you grade the gynecomastia? What is the current line of line of management that we prefer? And again, the various things as to the if let's say that if in the puberty, then whether you are taking an endocrinology consultation or not, whether you are outlining the factors that are leading to the gynecomastia or not. So all these common questions as to approach to a case, not only that, when you see that yes, this has to be operated, but how you approach to the the gynecomastia case, that is important. You can go back to the gynecomastia chapter and you can see there's a chart also that has been mentioned, so you can read that chart. Again, another breast reconstruction. If you see here, then what has been done, these are two images again. So you see there is not very clear, but this is the arm, that's the back, and that is a scar that is present here, and this is the flap that has been present here. So possibly it's an LD muscle myocutaneous flap. Classification of flaps, Smith is Nahai classification, important. What are the other options for breast reconstruction? Important. I've already discussed many breast reconstruction slides. Interesting slide. What is the procedure being performed, and describe the various techniques for the same. So I don't know if you can make it out, but it's an end-on view or a head-on view of the scalp, and here you can see that these are grafts, follicular grafts that have been placed. What are the techniques? FUE, FUT mainly. What is the difference between the FUE, FUT? Classifications maybe of baldness may be asked, but in general, like you should just, this is a spot diagnosis, you should not miss this. Identify the procedure performed, discuss the healing timeline. Again, a skin graft, most likely. So I'll just give you a little background. So this guy had a tattoo of the guitar on his dorsum of the palm, and he had gotten it, tried to get it removed, by laser from somewhere, but he ended up with hypertrophic scarring. Then it was injected with intralesional kinacort that led to atrophic scarring, but the tattoo was almost near about, the shape of the guitar was still there. So then what we've done is we've taken him up for dermabrasion and grafting. So this is a thin, very thin epidermal graft that we have put. We've dermabrated and we've grafted. We've consciously obliterated the shape of the guitar, and I've gone a little around to debride, to dermabrade it, so that the shape of the guitar is no more visible. So let's say that if you are given a tattoo, the image of a tattoo, as to what are the options to remove it. So you will definitely, the first option is laser tattoo removal. You can be asked about the wavelength that is most preferred for that. What is the chromophore for it? Then what are the other options? If the tattoo is small, you can say that yes, we can go for serial excision and grafting depending on the area that is present. If it is on the volar aspect of the forearm, definitely you're not going to say that serial excision with a large tattoo, no. So if at all you have to do a single stage, then you have to excise it and then put a split thickness graft. And then management of the graft, the timeline of healing of the graft can be asked. Again, the theory questions, they come after that. So instead of this, you can just be given an image of a tattoo and asked about your approach to the case. So again, this is a meshed graft. You can be asked questions about meshing, and that the mesher with the carrier plate present. And again, questions on skin graft can be asked. This is the ratio of the minimum and the maximum ratio of meshing that can be present. Here Humbee's knife is being used for harvesting of the graft. What are the other options for harvesting? There's a dermatome also present, so we can use that also. Advantage is that the thickness is more controlled in the dermatome. So again, here the white, what is this that you can see? This is the dermis, the whitish thing that you can see, and that's the skin graft. You can be asked about the different thickness of the skin graft. How will you dress the donor area? Dressing of the donor area is whether you dress it like the graft, whether you open the dressing in 5 days, you don't, because you leave it on for 3 weeks and it heals on its own. All these are like, common questions. Polydactyly, you may be asked the questions about classifications of polydactyly. So, management, not really. Spot diagnosis, this is Treacher Collins syndrome. You can be asked about Thaizia classification as to what is the principle of Thaizia classification, just broad things about from where to where you have the classification of 0 to 7, then 8 to 14, what about 30. So, these are basic questions in Treacher Collins. What are the clefts that are present? What are the common deformities that you can see in this diagram? So, you will mention prominent ears, you will mention coloboma, you will mention maxillary hypoplasia. Then, on one side you are seeing the microtia. So, different, all the if you're asked Treacher Collins, then you should be able to say at least 8 or 10 defining features of a Treacher Collins syndrome. Again, spot diagnosis, what is this, and from where the cartilage has been taken. So, this can lead you to questions on microtia. It can lead you to questions on the healing of the cartilage. It can lead you to questions about Nagata technique, about Brent versus Nagata. So, all these are questions that you can be asked. But again, basic, and in the basics, just what is Brent, how many stages, what is Nagata, how many stages, which uses more cartilage, which uses less cartilage, and what are the different stages. So, all these can be asked. Now, this is an image, if you have to comment, this is the umbilicus that you can see here, that's the pubic area, and in between you can see a dark patch of skin. So, possibly this is a patch of skin that has necrosed. How will you manage? Most important is debridement, and again, wound culture sensitivity is prerequisite, debridement and cover. But in this case, whether you need a cover or not, whether you will need a graft or anything, because it's the lower abdominal area usually lax, so you can actually debride it and close it primarily. So, this can be debrided and it can be closed like an abdominoplasty wound. So, this is important. You will put a drain, definitely, that is also important. What does this marking show? Just spend maybe 10 seconds before I write the answer. It shows the marking of the groin flap. Questions on groin flap: what is the blood supply of the groin flap, and what is the extent of the flap that we can take? What is it most commonly used for? It's mainly used for the dorsum of the hand defects, and it's a pedicle flap. Then what is delay phenomenon, you can be asked. How do you delay the flap? All these questions can be asked from this diagram. Tissue expander being used for the scar that is present, can be asked questions on tissue expander as to how how many stages are needed, how you plan, how many times you can actually expand the skin, what are the changes, basic changes that occur in the expanded skin, then when do you start expanding, till when do you expand. So, all these are common questions. I have dealt with tissue expanders in the chapter in detail, just go through that, but this is a spot image which you should not miss, that a tissue expander has been done for the, and what we do is advancement over here. So, here we have done it for the excision. So, in the second stage, what we will do is we will excise and advance. Here, this basically shows compartment syndrome, oblique, scald, probably early stages, scald burn of hand. So, again it can lead you to different questions about the compartments and as to what is the management. So, definitely the first management is limb elevation, dressing, all this is important, and if you see signs of infection, antibiotics have to be started, and again questions about splinting, functional position, all these will come with this slide. And this is an interesting slide. What do you see in this? I'll just give you 10 seconds maybe. So, here you can see all the fingers are flexed except this. So, what is the possible injury that is present in this? the possible injury is of the FDS tendon. Okay, so can lead to questions on tendon repair. Again, this is question on reimplantation. Now, reimplantation, there are controversies present, but if you have to just understand as to, how do you proceed in the case, definitely first what you will do is debridement is needed. You have to see the warm ischemia time. Warm ischemia time needs to be seen, warm ischemia time, and then you approach the case. Skeletal stabilization is important. First of all, skeletal stabilization, then depending on warm ischemia time, whether you do the vessels first or not. But after the debridement, the bony shortening needs to be done. Bony shortening usually is done in the distal stump, not the proximal stump, because let's say if your reimplantation doesn't survive, then you should have the length of the limb at least. So the debridement, the skeletal fixation, then comes the tendon repair, then comes the vessel repair, the nerve repair, then the skin coverage. So, but yes, there are controversies existing in this, but definitely skeletal stabilization, debridement and then skeletal stabilization are the first two options. Here, what you see is facial nerve palsy. You can be asked which is the normal side you think. So, obviously, we know that this is the normal side which is functioning. Although it looks like the abnormal side, this is the normal side, and you can be asked about management, the gross management of facial nerve injury, as to what are the options, dynamic options, static options, gold weight, all these common questions that can come from that. But not the details, but definitely you should be knowing free functioning muscle transfer, what are the options present, the temporalis muscle transfer, then the static slings that we can do for the facial nerve injuries. So all these are important questions to answer. Torticollis, again, just a spot diagnosis, but torticollis, how do you manage? Release can be done in the initial stages. We can do splinting that can help. So again, facial fractures, very, very important topic. Approach to the management of facial fracture. The examiner would like to listen that whenever you are dealing with any burn, trauma, emergency, anything, ABC has to be said first. Airway, breathing, circulation definitely has to be the first point in management, and after that only you approach. So let's say in this case, what are the possible possibilities? What do you think? What all will you examine in this case? So definitely you will you see that there is a raccoon that is present. So it could be possible that a fracture is existing. It could be a tripod fracture. It could be an infraorbital fracture. Again, from the reference point of view, an ophthalmic examination is very important. You see the consensual light reflex, the pupillary reflex, that has to be seen, and rule out the retrovalvular hematoma. Where the movement of the eye needs to be assessed, whether there is any trapdooring present or not. Then the continuity of the skeletal, all the margins needs to be seen, the supraorbital ridge, the infraorbital ridge, whether the mouth is opening or not, why the mouth opening can be restricted. You should know that it can impinge on the coronoid process and it can lead to the restriction in the mouth opening. Then, after that comes the management as to how will you manage this case. So obviously the first option is always debridement. So you will have to, if you are not saying debridement, then it becomes a problem. So whatever is you think is non-viable has to be removed. And then comes the identification of the fracture, of course, identification of the fracture, then debridement of the bony pieces that is present over there, then plating. Approach can be, external approach, internal approach. I've already dealt with all the fractures in great detail in the facial fracture chapter. You can go back and read, but approach to the case is important. ABC, the ophthalmic examination, the eye movements, the opening of the mouth, and then of course finally the fracture. What fractures can be present? So you can have a tripod fracture here, you can have an infraorbital rim fracture here, you can have an orbital floor fracture here, you can have, although uncommon, but superior orbital rim fracture not common again. So all these are possibilities in this case. What may be the associated injuries? How will you rule out? So obviously with examination, all others can be ruled out. There has to be definitely a neurological assessment, that is also important. Ruling out neurosurgery, ruling out a neurological, trauma is very, neurological deficits is important. So all these become the important point in management in the approach to the case of facial fracture. Again, plating has been done for a parasymphyseal fracture. Here you can see this is the midline, and it says parasymphyseal fracture. Here there's a fracture here. So obviously questions regarding parasymphyseal fracture, what can be an associated injury? So opposite condylar fracture, subcondylar fracture can be there. You can be asked about the Guardsman fracture. Guardsman fracture is actually when the symphysis pubis is fractured and bilateral subcondylar fracture is there. So again, approach to the case, same things. If we are approaching this case, then debridement is important, and then you can be asked about few things about the plates as to how will you fix and what do you think has been done here. It's a parasymphyseal fracture that you have to identify is the most important thing here. Here, what is the fracture that you can identify? It's the FZ fracture, the frontozygomatic fracture. What is it commonly associated with, or what other fractures can be present? You have to know that. A tripod fracture you will have to say in this. Approach to the tripod fracture can be external, internal. So internal, we fix the maxillary fracture in this case, and in the external we do the frontozygomatic. So again, here there's a lip defect we can see. This image can lead to questions about again management, approach. Debridement becomes the first option, but of course we have to assess what is the defect, and then how will you manage, what are the types of lip defects that are present, what can be closed primarily, and then what is this that you are seeing here. This may be if such an image is presented, you may be asked to identify an important thing here, and this could be the facial artery, the branch of the facial artery that is traveling over here. So these questions, again I'll just skip this. I mean, it's a large defect. What are the options for reconstruction? Free fibula has to be your answer, and then questions regarding the free fibula flap. This is what kind of a plate is this? This is a recon plate. Why so many? Possibly comminuted fracture, that is why so many plates. And then this will be again leading you to questions about facial fractures and how do you manage the top to down approach or down to top approach. You know that already, and I've discussed it in the questions also. And definitely ruling out other injuries also with such an extensive fracture. Ruling out other injury, post-op physiotherapy is important in the anything relating to the mandible. You will need to say that post-op physiotherapy, mouth opening exercises, these are important. Questions about cleft lip, commonly shown, the slides of cleft lip. Again, here when you are asked as to the rule of 10, commonly asked, but what is more important is that if the parents come to you, then what is most important is counseling, is the information about feeding the child. Feeding the child, what are the options? Gavage feeding, if we are feeding with a bottle, then what is the angle at which the mother will keep the baby, the constant intermittent burping that is needed. So these are important so that the patient can reach to a stage where surgery can be performed. And of course the basic classifications and all, these are common things, but identifying the deformities that are present. So the nasal deformity that is present, what about the arches, the collapse of the arch that you can see in the bilateral cleft palate. You may be shown the prolabium that is present here. So all these are just identifying an approach, again reiterating the same things again and again. This is PRP, platelet rich plasma, used in a lot of cases nowadays. Just read up, this is very commonly done nowadays, so you may be asked about this also. So I can go on and on with the slides, but just common ones, I'm just rushing through them now. Markings for, you may be asked to identify a very common workhorse flap, ALT flap. You should know what is the markings, what are the markings like, and what are the landmarks for marking, what is it used for commonly, and some variations of the ALT flap. Now just so that this is a coupler, and used in microvascular anastomosis. It speeds up the process, it makes it more accurate, and if you are asked about Carroll's technique and all that, you can say. This is an important slide. NPWT, negative pressure wound therapy, you should not miss it. You can see that this is traveling here to the vacuum pump, this is the foam, and this is the occlusive dressing that is present. Hyperbaric oxygen chamber, questions relating to that. Dupuytren's contracture, in great detail I have already done this chapter, go back and read it. Etiology mainly, and what is the management. Here management can be asked. Neck contracture, very important. Again, how do you avoid this? Physiotherapy, early grafting is important. Splinting is important. If we release it, what is the picture frame, phenomenon, and how do we fishtail and all? This can be asked. So, contracture release. At one side, what do you think this infection is? I think you can't miss it. It's Pseudomonas because it's green. And then again, management, wound swab, antibiotics, again debridement, and then possibly a flap cover we are looking at. Venous ulcers, questions regarding venous ulcers could be asked. What are these things surrounding in the area? You can see hemosiderin deposits. This is general surgery question. I'm just skipping it. Again, grades of pressure source. Neuropathic ulcer, most commonly in the diabetic foot. Pectus excavatum, spot diagnosis, nothing really for management. You will, nobody expects you to know the management, but if at all, then, you should know that it is pectus excavatum. Kind of an obscure slide, but still, if you're given to compare, then what can be the possible etiology? It could be whether do you think it is lymphedema or what. So, what is an emergency, diagnosis that could have an emergency, setting. It is DVT, where you are seeing that the calf size is increased. A liposuction cannula, you can be asked about basic things about liposuction. What is Timmerson solution? What is Timmerson technique? And just the basic as to what are the layers of fat that are present. Not too much in detail. Again, here, okay, this can be important. You see here, this is a recon plate, you can see, but what has been done here? You see, this is here, half of the mandible has teeth, half of it doesn't have, but you can see a plate that is going through. So, this is a free fibula used for reconstruction. Again, spot diagnosis. If you are asked what has been done, possibly an abdominoplasty, not possibly, it is an abdominoplasty that has been done. And what do you see here? Whether it is, so it's bruising that commonly occurs with liposuction, and basic things about what is mini abdominoplasty, what is full abdominoplasty, maybe. This is just to give you a brief overview of what OSCE can look like. Obviously, there are so many, innumerable questions that can be there, but what I'm reiterating every time is that the approach to the case is more important than you knowing the management of the case. Nobody at your level will expect you to know the management. When you are looking at the slide, say the common things, think calmly with your head on your shoulders, and then approach to the case. You have to tell the examiner in, as simple as possible. For example, let's say in the burn management, if somebody asks you, how will you, let's say, a case of burn has come roughly, say, let's say 50%. You have to say that first you will assess the ABC, then what you will do is you will secure an IV line. After that comes the assessment of the percentage of the burns. Then you will, instruct or start to dress the wound. Then after that, it is important for you to say that you will prepare a medico-legal report also. That is also a part of the management. The medico-legal report has to be sent. So obviously, for people who've worked in the burns department, the plastic surgery department already, these are reflexes. But for people who've not worked, then these reflexes you will need to inculcate so that those answers come out automatically. I hope that this is helpful. I'll be taking questions at the end of this live session.
Hello. So thank you for joining in the live session. I am ready to take up questions now. I hope that the live session was useful and the lecture. So Samanvita has asked, what are the other patterns of questions other than images can we expect in the interview, and what should we focus on with regards to basics? Samanvita, see, mostly it will be pictorial, because it is since it is online, and had it been offline, you could have instruments, you could have different, maybe some clinical cases also could be kept. But in the online, it is mostly image based. But still, if you want to ask about the other things that you should know, you should definitely know about the, for example, the two broad headings that I'm talking about is, or three rather: general plastic surgery, burns, and maxillofacial trauma. So these are the three broad headings that you should be prepared with. Now, other than that, you should be, within that, let's say if you're talking about burns, you should be ready with the formula of burns, as in, and the Lund and Browder chart, how you are calculating the percentage of burns. All this is important because it is a part of the initial assessment. When you're talking about maxillofacial, you should also know about the management of the ABC. If normally it's not asked, not very common to ask by, be asked by a plastic surgeon, but still, I mean, you should know how you are performing any initial resuscitation in a trauma patient. Then examination, common examinations, for example, nerve injuries, how will you rule out? Let's say if you're asked about a hand trauma case, then how do you rule out whether, how do you do the sensory testing, how do you do the motor testing, the testing of all the tendons? So all this is important. How do you how do you rule out that the FDS, let's say, is not injured, or FDP is not injured? So all this is an important part. Ulnar claw hand, median nerve palsy, all this is ulnar nerve palsy. This is also important. So regarding other questions, again, most you can be asked theory, but again, among the theory also, you have to really just, once you are going through the lectures, from the first one to the last one, you can just actually filter out that, and you'll know that this is a question that can be asked in the OSCE, because generally they will not ask very theory based questions. Another thing that I think I should have included a slide, which I missed including, is the local flaps. Local flaps are very important to know, especially at your stage. The bilobe, I think I did mention bilobe flap, the Z-plasty, Romberg's flap, deformental flap. All these are important topics, and you should be thorough with the design, as to, and I, of course, identification. If they throw at you any particular flap, then according to the design, you should be able to identify what kind of a flap is that. Other than that, the hand anatomy is important. You should be able to identify the individual carpal bones, and then different anatomical landmarks of carpal bone. Scaphoid is a very favorite of the examiner. Scaphoid bone, many times they will ask, it will lead to the fracture of the scaphoid, and then the avascular necrosis. See, there's innumerable questions that can be asked, but still, in the hand chapter, I think anatomy, the radiological findings, these two are important things. The nerve palsies, they are important. In the I just have this book in front of me. And yes, another thing, vascular anomalies, hemangioma can be asked. Hemangioma, port wine stain. Then in the melanoma chapter, I did deal with SCC, but yes, you can also be asked about melanoma. For example, the periungual melanoma. It's a very pictorial, that diagram is very, very telling. So that, then again, identifying electric burns is important. Volkmann's ischemic contracture. Then, the signs in the hand injury, also the Froment sign, and all other the tests that we've mentioned, we've read already. So all those, so common thing in examination, you can be asked more than the management. So I think, mostly pictorial, but other than that, you should be knowing the initial examinations for particular cases, and the loco-regional flap is very important. In the general plastic surgery, I would say that I think I've already discussed quite a few of the slides in general plastic surgery. You should be able to identify typical instruments. For example, let's say if they show you a distractor, the image of a distractor, so you should be able to identify that this is a distractor. Like I showed you the coupler. It's an uncommon thing to ask, but still you should know that that it's a coupler. For example, the Humvee's knife, the Downs blade, the dermatome, the mesher, all these are important images that you cannot miss to identify. Pratap is asking, what are the kind of timeline that we can be expected to be given for each of the questions at the first instance? Um, uh, do you mean to say that how early the examiner is expecting an answer? Is that what you're asking? Because you say that what are the kind of timelines, what are the kind of timelines can we be expected to be given for each of the questions at the first instance? See, I think you can easily take about 15 to 20 seconds to delve on the image that is thrown at you, and nobody will expect a reflex answer out of you. So if you the examiner will actually appreciate if you actually take time to look carefully at the image or read the question. Sometimes the examiner can also throw an MCQ at you, a common one, maybe one liner with ABCD option possible. But they will actually appreciate if you really spend some time reading the question or seeing the image, going into the detail of the image before you start your answer. Because once you start your answer, remember, one thing is going to lead to the other, and it is on the examiner's choice where he or she would want to stop. So I would actually advise you to spend some time once the slide is thrown at you. Don't just jump into answers. There's really very less brownie points to give a reflex answer. All right, so you must spend some time reading the question and looking at the image that is given to you. Will only our technical knowledge be assessed in this interview? Deepak, that's a good question. No, actually, they're not looking at your technical knowledge. If I'll be very, frank with you, that they are not really looking at how good a plastic surgeon you already are. As I told you in the beginning of the live session, the lecture, that they're actually wanting to assess whether, okay, initially, see, at some, especially in institutes like AIMS, most of the work is supervised. They're not wanting you to be a full-fledged plastic surgeon when you enter your MCH course. So basic things which you would have learned in your general surgery also. So that is very important. That for example, managing a trauma case, the initial approach to a trauma case, initial approach to a burns case, whether you are able to manage simple emergencies on your own or not. So suturing techniques can be asked, suturing techniques, hemostasis technique can be asked. Maybe some details about local anesthesia, nerve blocks can be asked. This is also another thing that is important. How do you administer local anesthesia? How much do you wait after administering a local anesthetic? Then what are the kinds of, let's say that you are alone in the emergency, you don't have an anesthetist available, you are presented with a burn with a wrist trauma, or maybe an elbow level trauma. How will you manage without the anesthetist? So then you should be ready with answers like that. You'll be using the block. The regional anesthesia can be, which again the residents are expected to know. Of course, I mean, I'm not saying that you should know it in great detail, but at least you should know that regional anesthesia or regional blocks can be given. So that is an answer which the examiner is actually expecting from you. Rather than knowing the details of the block, at least know that the block can be given even without the anesthetist being present. So Janet says, thank you. You're welcome. Any last minute reference material? See, last minute reference material, don't go for any new reference materials. Revision is the only key to sustained, recall of what you already read. If you're going to look at new images, look at new text, you will not retain most of it. So I would say that maybe just go through Grabs and Smith is something that we in our times also, about 12 years back, we also used to refer to the same book. Of course, the new edition is there and it's very pictorial as well. So I will say that, just run through the images given in any standard textbook of plastic surgery, be it Nelligan, be it Grabs. I think Grabs is a more relatable material for you. Nelligan is going to be very vast, you'll get lost in that book. So don't go into new texts, please. Yes, for the common things, as in, if you're really interested, for example, general plastic surgery, you can look at Nelligan also, but I think for ready reference material, Grab and Smith is really sufficient, because they're mostly going to be pictorial, mostly. Even also look at the charts, and in general plastic surgery, please do revise your classification of the muscle flaps. That's very, very, very important. Common things like identification of a faciocutaneous flap, at least you should know. The markings of common flaps, the LD muscle marking you should be knowing, the PMMC marking you should be knowing, ALT flap marking you should know. Then the deltopectoral flap, also you can you can look into the free fibula. So, if the examiner is giving you an image of a free fibula flap, then at least you will be able to say that yes, this is a free fibula being planned. And then it can lead you to the question that, where is it planned for most commonly. Then in that case, you can say that it is used for mandible reconstruction. So, common things. But again, I think at your level, general plastic surgery is very important, including the topics of melanoma, the squamous cell carcinoma, basal cell carcinoma, the hemangioma, vascular anomalies are important. The Burns chapter is important. Hand anatomy and peripheral nerve injuries is important. The Burns maxillofacial I already have said. So I think these will be the takeaways that I would like you to have from this live session. Other than that, yes, head and neck, as in maybe not the details of reconstruction, but interesting flaps. Like in the lip, if a carapanzic flap has been marked, then you should be able to tell that yes, this is a carapanzic flap that has been marked. And other than that, tasia clefts I already mentioned. Aesthetic surgery, not very important for you, but like common topics like gynecomastia, abdominoplasty. If a post-op case of abdominoplasty has been shown to you, you should be able to identify that yes, an abdominoplasty has been done. So also breast, yes, breast reduction, the pedicles that are used, not very great detail, but pedicles, silicone implant, you should be able to identify. Silicone breast implant, you should be able to identify. I think that that will be more than enough for your stage. Can you please help us with high topics that we must prepare for? I think Vaishag. Vaishag, I already told you, but if you want me to just look at the index and let you know, I would say that in the blood supply of skin, you should know the angiosome concept. The general plastic surgery, I think for you, the important one is the local flap, the loco-regional flap. In the blood supply of skin, angiosome concept, you should know. You should know the common implant materials. All right. You should also know in the principles of microsurgery, as I showed you the coupler, you should also be able to identify the bulldog clamps. You should be able to know the Carroll's technique. If the diagram is being shown to you and then the 120-degree sutures are shown, then you should be able to identify that yes, it is the Carroll's technique. Tissue expander, I already told you. Apart from that, in the skin and soft tissue, the melanocytic nevus, that also I've dealt in the slide. In the burns, I already told you the degrees of burns, Jackson's zones, the Lunden-Browder chart, rule of 9, all these, the formulae. In the anomalies in pediatric plastic surgery, the vascular anomalies, cleft lip and palate, important topic, because it's very pictorial. See, whenever you see that a topic is very pictorial, that has to be a high yield topic for you. So let's say if they throw at you the Carnahan Y stripe classification, stripe Y classification, you should be able to say that what it means, or the Lashal classification, you should know. that what it means. And even for the head and neck, I already told you. Let's say that mandible reconstruction is important. Facial paralysis, again, when you say facial paralysis, you should be able to say what are the divisions of the facial nerve, and in general, the defining features of facial nerve palsy. Apart from that, I would say that if I were in your stage, I would definitely look at all the flaps in detail, and I would look at even the hand. I already told you. The tendon injuries are important. Because the tendon injuries you'll deal with right from the day one of your residency. So that is important. So go through in detail the tendon injuries examinations. So these are important. All right. If there are no further questions, I would like to wrap up this live session. Thank you for joining me in this live session. I hope that this has helped you in some way, and wish you all the best for the upcoming interview. I think it's on the 22nd. Wish you all the best, and don't get disheartened if you don't get through. There's always a next chance, and prepare for the next examination. Go through the topics, recall the topics, don't read anything new. That is my sincere suggestion. Grabs and Smith for this is more than enough for you. Go through the pictures in there, and look at the pictures, spend some time, don't rush to an answer. All right. Thank you very much for joining me. And in case if you have more questions, do leave them in the comment box. I'll look at them, and then I'll definitely answer them as well. Thank you. All the best. Bye bye.